Hello, good morning. I'm Ashok Kurokode, consultant rhinologist and anterior skull base surgeon from Winchester and University Hospital, Southampton, UK. I welcome colleagues from around the world on behalf of organizing team to the second day of inaugural Winter Global Rhinology and Skull Base Surgery Webathon. Global Rhinology Network is a non-profit organization with a mission to foster surgical education in rhinology and skull base surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We had hugely informative and engaging 15 sessions on endoscopic sinus surgery presented by eminent rhinologists and skull base surgeons on day one. We'll be having similar sessions today focused on anterior skull base surgery. This event is hosted at the Global Telemedicine Studio of Professor Wilco Grolman in Utrecht, the Netherlands. It is supported by Medtronic and Karl Storz.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
And it's again a pleasure to introduce Paolo Castelnuovo. I think Anshul Sama already made a very nice presentation, and I only can extend mine saying that we both share our love for big cigars. We also share our love for big motorbikes. The only difference is that I don't have the tendency to have motorbike accidents like you do. So
That's right.
Said this, I can only say that if I had a malignant tumor in the nose or paranasal sinuses, Paolo would be the guy to do the surgery on me. So Paolo, it's a pleasure having you here again. I'm looking forward to hear you.
Thank you, Manuel. Thank you for your joke. So we move immediately to share the lecture, my screen, and first of all, I want to give you greetings from my city, from Varese, and want to acknowledge my neurosurgical partner, Davide Locatelli, and then greetings from the Skull Base Society and the Italian Skull Base Society, and from Italian Academy of Rhinology. So the major challenge in the malignant tumor of the nose and anterior skull base is the number and the variety of the histotype. This makes really difficult to manage with the right choice these tumors. So this make mandatory to manage these tumors to approach with a tumor board, because there are so many, and to have the consideration regarding the outcome, the statistic result is quite difficult with such a number of rare tumors. So for that, the histology drives our therapeutic decision. We can have a surgery plus chemo and radio, or chemo and chemo-radio exclusive. But we have to consider these different strategies. So in our works, we very, very often ask for second opinion, for pathologist's second opinion, for revision of the histology slides. This is to confirm the histotype, to understand the grade of the differentiation, and to plan, following that, to plan the correct therapeutical strategies. But the second opinion, you have to ask in centers with dedicated expertise. So sometimes we have to ask for a second opinion in center outside of our region. But all the time you lose for this second opinion, you get in the therapeutical process. After having this second opinion, this right of the different histotype, we can divide in three major groups: the high-grade tumors, the intermediate-grade tumors, and the low-grade tumors. And you have to consider different therapeutic approach in the different grade. And then you have to match with the extension of the cancer. For the extension of the cancer, it's mandatory to have magnetic resonance. And also for that, sometimes we look for center where they are really skilled, really expert in magnetic resonance. Because sometimes to understand the relation between tumors and the structures surrounding the tumors, like tumors and periorbit, tumors and dura, tumors and brain, are mandatory to decide the different surgical approach. So we know that we have endonasal, combined endonasal transcranial, and standard craniofacial resection. There is no any competition between the different surgical approach, but different indication. And then we have to consider the patient profile, the age, the comorbidities. Sometimes the comorbidities preclude the use of the surgery or also of the chemotherapy. In some patients with the cardiac comorbidities, we cannot use chemo. So all these different issues, the biology of the cancer, the extension of the cancer, the patient profile, has to be discussed in the tumor board. We do not move for treatment in a single patient without a deep discussion with the tumor board. And as a surgeon, we have to know when the surgery is not the first treatment option. So we have to consider, once again, the different grade. In the first stage, the high-grade tumors like SNAC, G3 squamous cell carcinoma, Ewing sarcoma, the first treatment has to be chemo and chemoradiation. And we will see if the result after 3-4 cycles of chemo is a reduction of the volume of the tumor more than 80%, we move for chemoradiation exclusive. For the intermediate grade adenoid cystic carcinoma, squamous cell carcinoma, we have to move surgery plus radio. And for a low grade, main surgery, and in the 70% of cases, we do adjuvant radiotherapy. But we will see that we have to consider the subtype of these different tumors. For instance, for olfactory neuroblastoma, if the olfactory neuroblastoma is a type with a EMS type 4, these have the biological behavior, the behavior of this tumor, is like the first high-grade tumors. So we will see. We can have, in this case, in the first very aggressive tumor, a protocol with a multidisciplinary consult and with induction chemo. And then we have two arms, the one after induction chemo surgery, and the second one we move for chemo radio exclusive. It's related to the extension of the tumor and to response to chemo. If after 4-5 cycles we have a reduction more than 80%, we move for chemo radio exclusive. So no surgery in this patient. And the first group, SNOOC, for this tumor, SNOOC, NK, squamous cell carcinoma, poor differentiated G3 squamous cell carcinoma, we do perform chemo first. And then, related to the reduction of the volume, we move for trimodal surgery. And look the outcome. The 5 years overall survival of SNAC, squamous cell G3, and NK squamous cell is quite different. And the SNAC have the better results. And this is an example of SNAC with the poor differentiated squamous cell carcinoma. We move for induction chemo, and after induction chemo, there are reduction of the tumor, but less than 80%. So we move for endoscopic endonasal surgery, and the outcome after 38 months is net. So appropriate treatment in this case is the SNAC and is induction chemo. And it was a T4B and 0M0. After 4 cycles of chemo we have a reduction, important reduction of the tumor, but less than 80%. So we move for endonasal resection of the tumor, monolateral endonasal resection of the tumor, leaving the orbit, and then the reconstruction was done with the flip-flap techniques. So with the first two layer with the fascia lata, and the third layer, the mucoperiosteum of the septum. And you can appreciate the resection of the tumor, then the endonasal craniectomy, the resection of the dura, and then the skull base reconstruction with the first two layers with the fascia lata, and then the first two layers with fascia lata, and then the third layer with the flip-flap. So we preserve the mucoperiosteum of the septum, and now we rotate the mucoperiosteum of the septum of the right part. In this way, we preserve the olfactory fissure on the right side, and we can preserve also the olfaction. Another case, this lady complained nasal obstruction, anosmia, epistaxis, and the first pathology report was olfactory neuroblastoma, EAMS 3. After revision, after second opinion, we move for second opinion before approach the treatment. And after the second opinion, done in the very expert department, the second opinion was poorly differentiated neuroendocrine carcinoma. And we move for induction chemio with the cisplatin ectoposit, and then with the result of the reduction of the tumor more than 80%, we move for chemoradiation exclusive. This was the result after 3 months and after 1 year. And the consideration. EAMS type olfatoneuroblastoma, EAMS 1 to 3, we move for surgery plus radiotherapy. EAMS 4 is a completely different tumor. It's like neuroendocrine. So we move for chemio. And then, in relation to the reduction of the tumor, we do chemoradiation exclusive. And of course, olfactory neuroblastoma, EAMS 1 to 3, is a radical approach with the surgery plus adjuvant immunotherapy, radiotherapy. Neuroendocrine is different. Neuroendocrine is worse. And the induction chemio and adjuvant chemio, you can appreciate the overall survival and the disease-free survival of this first group of very aggressive tumor. 5 years overall is 54. Disease-free is 35. Is quite a poor outcome. But if you look inside the different histotype, the SNAC is the one with the better result. And the neck and the mixed with the neuroendocrine component is the worst, absolutely. 10 years overall survival. No one patient survived. 29% in the neuroendocrine. Much more better. The same for the disease-free survival. Look the difference in between the first aggressive tumor. And these are the results for the olfactory neuroblastoma. Of course, olfactory neuroblastoma is considered in the third group, in the low aggressive tumor. And the results are in the overall survival, and 5 years is 90%, 10 years is more similar. The disease-free survival is less, lower, but still good. But if we compare the group EMS 1-2 with the group EMS 3-4, we have a very worse result with the EMS 3-4. So EMS 4 is really a different tumor comparing with the olfactory neuroblastoma 1-3. And we have to consider in the first group of the tumor. Now we move in the second group, intermediate tumors, and we consider adenoid cystic carcinoma and squamous cell carcinoma. The standard treatment for the squamous cell carcinoma approach is surgery plus radiotherapy. Once again, we have to consider the subtype. In the G3 squamous cell carcinoma, it's much more aggressive. We have to move for chemo radiation, for chemotherapy adjuvant first. And this is a case of a squamous cell carcinoma in the posterior ethmoid and in the bottom of sphenoid. And this was the surgery. We have to resect all the bony boundaries of the tumor. We have to resect all the floor of sphenoid sinus and to expose the pterygoid, to resect the part of the vomer, and to resect part of the rhinopharynx, and to have at the end all the frozen section around the tumor negative. Of course, the first target of the surgery is the free margin resection, and we choose the different approach, endonasal or craniofacial resection or combined resection, combined approach, comparing the possibility to reach the free margin resection. So the pathologist live in the OR with us, and we send to the pathologist more than 10, 15 samples to be sure that our surgery has in the free margin resection. This is the after 1 year, the outcome. But once again, look the squamous cell carcinoma. The overall survival, 5 years is 77, 10 years in 62%. Of course, it's more lower the disease-free survival. But once again, if we consider the G3, so the more aggressive, we cannot put together with the G1 and G2 because the outcome, 10 years, is much lower. So the G3 squamous cell carcinoma we have to consider in the first group. The salivary gland type carcinoma. The standard approach is surgery plus adjuvant radiotherapy. This tumor has a good value of the overall survival, much worse the disease-free survival. The characteristic of this adenoid cystic carcinoma is the recurrence, is the group of tumor, is the histotype that has the major recurrence rate, 40 to 60%. And of course, in between the adenoid cystic carcinoma, the purging solid type 3 has the worst result in survival, you see, with a significant. Another issue is the perineural spread. More important is the perineural spread, worse is the outcome. In the last 10 years, the adjuvant radiotherapy in adenoid cystic carcinoma, our program is with carbon ion therapy. And we have a collaboration with the CNAO Center in Pavia for the proton and for the carbon ion therapy. This is a case of adenoid cystic carcinoma invading the cavernous sinus. In this case, was a G1 T4B, and the decision of the tumor board was no surgery, but radiotherapy exclusive. So carbon ion therapy, and after 3 years is net. A good control of the disease without any therapy. So in adenoid cystic carcinoma, in relation to the location, when it's located in the cavernous sinus, the decision of the tumor board in the last year was no surgery, no debulking of the tumor, but primary radiotherapy with carbon ion. And this is the overall survival after 10 years is a very good value. The disease-free survival is much worse. Why? Because we have a rate of recurrence very high, 35%. What about the low-grade tumors, the third stage? Adenocarcinoma, olfactory neuroblastoma. Adenocarcinoma is our main subgroup. Is the high majority of the tumor we have in our cases is intestinal type adenocarcinoma. And the gold standard is surgery for T2, T1, and T2, low grade. Surgery plus radiotherapy for T3, T4, and high grade. So combination the T and the G. And only when we have functional P53, we do perform chemo first, adjuvant chemo first. Of course, adenocarcinoma intestinal type adenocarcinoma is an occupational disease. And we all know, so the occupational doctors are in our tumor board. And once again, different behavior between G1 and G3, very, very different. If we consider G1 and G3, there is the statistic significance, and you see how worse is the curve of the G3. So we have to know before the treatment the subtype. And we know that papillary type has a much better outcome. The mucinous type, especially the signet ring cell type, has the worst prognosis. 15 years ago, we didn't understand why. Same histotype, adenocarcinoma intestinal type tumor. Same extension. We have patients with very worse outcome. Now we know the subtype mucinous signet ring cell is completely different tumor, not only for their overall survival, but especially for the disease-free survival. The difference between the different histotypes is with statistic significance. And also the non-functional P53, comparing with the functional P53, has really statistic significance. The not functional P53 has the worst outcome. And after chemo induction, after chemotherapy, adjuvant chemotherapy, the group with the functional P53 has a really better outcome. So we have to know before starting the therapeutical program in this tumor, if the P53 is functioning, we start with chemo, not direct with surgery. Of course, we do a bilateral approach for many years. Nowadays, we do monolateral approach in a T1, T2 procedure. An example of endonasal approach with the endonasal resection, with the resection of the skull base, resection of the dura. We send the frozen section to the pathologist, then reconstruction with the 3-layer of fascia lata, as usual, the first layer intradural, second layer extradural, and then again in the monolateral procedure, we like to use as a 3rd layer the flip-flap procedure. So the contralateral mucoperiosteum is a very well solid reconstruction when it's possible, and in some cases we can preserve the olfaction of the contralateral side after therapy. So the blood supply of this flap is with the 2 septal branches of the anterior and posterior ethmoidal artery, and this was the result. Finally, the melanoma is the worst histotype. The melanoma has no indication for chemo, no indication for standard radiotherapy. We move for surgery first. And after surgery, we use the carbon ion radiotherapy. And in very selected cases, especially in the metastatic disease, we use the new immunotherapy. But the overall survival is very low. And we have no one patient with a disease-free survival after 10 years. And regardless any treatment we do, the final outcome is this. So in our series of 47 patients, the 10-year overall survival is 25%. The disease-free survival, 10 years, no one patient without disease. In the metastatic disease, in the metastatic patient, nowadays we can use the monoclonal antibodies with the nivolumab and ipilimumab with some good results, but we do need some years more for understanding the final outcome. So in conclusion, the right diagnosis, the correct examination, histopathologic examination with the second opinion is mandatory to understand the subgroup of these tumors, makes the right decision with the treatment between chemo, radio, and surgery. So the different surgical approach, standard cranioresection, craniofacial resection, endonasal, combined endonasal transcranial, are not with any competition between them. It's only different indication in relation to the extension. And remember, we do need the examination with very high quality magnetic resonance. And then the team has to be very flexible to approach the different treatment. And do we need always a discussion with the tumor board? I take the occasion to hope, crossing the finger, we can see each other really in face in the next November for Italian Skull Base Society, or in June, I don't know. But this is the hope of everybody of us, to restart to meet friends. Thank you.
Thank you so much, Paolo, for your outstanding overview on the treatment of malignant diseases within the nose and paranasal sinuses. I think you have probably one of the largest experience gathered about these type of tumors. I wonder whether there are questions. I didn't see any. And whether Wilco is ready with the mini poll we were waiting for before that. Okay. So a couple of questions to answer to your level of expertise. And show meanwhile, Paolo, in which cases do you ask for a second histopathological opinion?
Well, always when we receive a patient and the report, the histopathological report is poor. You know that in the last 10 years, there are all the new markers, and you can control in the report. If the report is well done with the use of all the new markers, okay, you can accept. But the report is poor. For instance, like an example, if I receive olfactory neuroblastoma and there is no the EM's grade, I always ask for second opinion. And then there are some very difficult tumors, especially in the first group, in the very aggressive group. So make the different diagnosis between neuroendocrine, between ANK squamous cell carcinoma, between the new group of small cell carcinoma like INI1. These are tumors with the very difficult, with the high level of difficulties in differential diagnosis. So in this group of tumors, always we ask for. And sometimes there are some sarcoma that are really very difficult to differentiate. And so we have the expert of sarcoma that in Italy now is in Padova, is Professor Dept, is the expert of sarcoma. Or we send the second opinion asking in Boston for the pathology of Boston for the sarcomas. For neuroendocrine carcinoma, there are different. They are in Varese, they are a very good team, but also in Milano, in the Institute of Cancer in Milano. Mm-hmm. So when you are working with different pathology, ask for different centers.
Okay, I agree. I mean, that's a very good point because it may completely change the therapeutical approach in patients. Ashok, I don't know how far we are. We should hand over to how we see the results, the current role. Most of us are general ENT surgeons, specialist rhinologists, and academic consultants in academic institutes. And a couple of you are also trainees. Very nice. Yeah. Okay.
Okay.
Ashok?
We have good attendance of the senior trained ENT surgeons today. So thank you, Paolo. That was excellent, very informative. And thank you, Manuel, for hosting.
Just Paolo, there are some questions in the chat. You can reply to them directly so we can proceed. Thank you very much. See you.
Thank you. Bye-bye. And thank you again for inviting me.
Thank you.
It's very nice to see you all.
Thank you.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.